this. You may feel like this is a waste of your time to go over basic cuff tough type stuff. But it is important. There's only one chapter of all of Technally that's dedicated to military medicine, even though military medicine was the spearhead of change for civilian trauma. So that entire multi-thousand page Technally, that is the Bible of emergency medicine, essentially, there's only one little dedicated chapter to the biggest population that has changed medicine, and that is military medicine. And do you all agree with that, that we changed doctrine, the way that we address traumas with the invasions into Iraq and Afghanistan, knowing that we're sustaining a different type of trauma, right? What's the type of trauma that's usually sustained in the United States? The most common? Yeah, it's multi-system blunt trauma, usually from motor vehicle accidents. Now, we did speak the other day about now death by gunfire is the number one cause of death in children, which is really unfortunate, and that's due to a myriad of things. We have safer cars now, right? We have airbags. There's laws that keep children in their car seats, but we didn't see traditionally that much penetrating trauma until the last decade or so in the United States. Whereas, like if you're in Honduras or something, they machete each other, right? So they don't see. They literally will machete you. So they don't see that high projectile, multi-system blast type trauma, but they still see blunt trauma and a different type of penetrating trauma. But anyway, military medicine is important, so bear with me, those of you that are super experienced, and this is just a recap of TC3, but I will go over some principles and kind of reiterate some things. Any questions about anything we've covered so far? At the end, I hope to do a demo. There used to be this ridiculous looking, usually half-naked mannequin up here that had like sweatpants on. They were always kind of down, like droopy drawers, and it was like sitting up here. I don't know if you guys did such a good job of cleaning that it's no longer here, or if somebody decided they wanted it at home. I don't know. You never know what goes through people's heads, but it's missing. So hopefully somebody will bring it up, and at the end of this lecture, I'd like to do a quick demo. Okay? Any questions? Fired up about military medicine? So does this apply to everybody in this room? You think? You think some people are exempt? What about Coast Guard? Do you think they're going to be doing some of this stuff? What about Air Force? No way. Yes, it applies to everybody. Okay. So I use Technally as my reference, even though we know that there's a TC3 committee. Do you guys all know that?
Yes.
Does everybody know what TC3 stands for? Tactical Combat Casualty Care. Very good. Okay, and so we're going to talk about that. It's a military-specific curriculum, so you're going to hear me actually define some of the things that I introduced on Monday regarding trauma. We kind of do the same principles, but instead of X, A, B, C, D, E, F, G, go to the ER, we're talking pre-hospital military austere environment. What does that mean? What's austere? Yeah, you might be the only one. I mean, when I was a part of the invasion into Iraq, I was jumping out of my tracked vehicle with a backpack of supplies and trying to treat people, and there was no cash, there was no air-evac. Okay, remember I told you, I promised you I'd project all my trauma on you, and that's what I'm going to do today. I'm going to be an emotional vampire, project all my traumas onto you. I would treat people, American casualties, Iraqi national, like local nationals and Iraqi National Guard and the Medina Division, all individually different groups of population, while I was maneuvering 13 vehicles on the battlefield myself because I didn't have a command and control MSC officer element. So I had all these vehicles I'm treating, I'm battle tracking, and there was no cash or anyone to evacuate these patients to. There was no air vac. So what was I doing with all those patients? What would you have to do? We would treat them and then pick them up and move them with us forward on the battlefield. So I had a vehicle full of Iraqi local nationals, which is a different vehicle that I put the Iraqi soldiers in, which is a completely different vehicle than I put the American soldiers in, obviously, as I'm scooping people up and taking them with me on the battlefield. That sounds pretty nutty. Don't you guys think? Now they're like, oh, you guys got to know about prolonged field care. I mean, that's been what you guys have all had to do. I'm sure all of you that have deployed before, we've done prolonged field care for a long time. They're just now making it an issue. But Anyhow, so how to prepare for that? There is no preparation for that, right? You just have to get, feet to the fire. But they do have now some set of principles that help guide us through these different phases of care. And assuming that there is still a somewhat linear battlefield, which is the battlefield linear?
Yeah.
Do we go in an open field and march towards each other and shoot and then advance some more and shoot? I mean, those days are over. What was the last war that we had like that? Yeah, Civil War time, right? So anyway, we're gonna talk about some of these phases of care, that's guided by the TC3 committee. Who makes up the TC3 committee? Who makes these decisions? I'm sorry, the committee of the Tactical Combat Casualty Care. Who's on the committee?
Guys from GTS, pretty much everybody.
Are they operational folks? Yeah, some of them are. Some of them are rangers. They have some from the SOC community. A bunch of physicians on the committee. A bunch of surgeons on the committee. Every now and then you'll see a few medics, which there should be a nice balance. And usually there's at least one PA on the committee, at least in an advisory role. You would hope that they would take medics and PAs as the advisors, as we're the front forward folks. But anyway, they guide the principles and treatments that we're all supposed to know when we go to war. And then we're going to talk about each of these phases and then some special situations, just kind of reiterate. So we're also going to briefly go over triage. Does anybody have a rapid method that they do triage? Anybody been involved in a mass cal before? What is a mass cal or a mass casualty incident?
Anything that exceeds your capabilities.
That's right, anything that exceeds your capabilities. So if I'm just one provider and I have 2 patients, is that already a mass cal? Yeah, theoretically, depending on what they need, right? If they just have a stubbed toe or something, probably not. But so we're going to talk about that real briefly, and then talk about fluid resuscitation and some of our assets that we have in our pre-hospital setting, and then pain control in combat casualty patients, and then antibiotic treatment. Okay, so care under fire. So what is care under fire? Y'all know this. You're being shot at, right? Is that right? Yeah, so what do we do under care under fire? Are we jumping out of our vehicles or wherever, or running out of the building and treating people while we're under fire, direct fire? I mean, we might be lucky, right? No, what's a priority right now? Return fire. It's called fire superiority. Do you think the command and control element or the commander of that convoy or anything like that cares about your medical skills at that moment? No, they want fire superiority and continue the mission. So during that, though, if you actually take casualties, at some point we're going to have to start treating them, right? And when do we do that? When can we do that? Yeah, hopefully after we've accomplished fire superiority, or what we call a tactical field care phase. So under care under fire, the priority is fire superiority. In other words, return fire. You're a combatant at that time. You're fighting. You're a war fighter. And then if there's an opportunity to get somebody off the X, which is the area in which you just took fire or casualties, if there's an opportunity, you're going to load and go, or get them off of that area and get yourself and that person to a more secure type environment, whether that's behind a vehicle or in a vehicle or behind a building or whatever. And that starts the tactical field care phase. Are we jumping out and dumping aid bags on the X as we're trying to pick these patients up? No, and if we do anything, what are we doing? Maybe just a high and tight tourniquet, and we're throwing a drag strap on the patient if we have to, and we're getting them out of there. Are we expecting ourselves to run up there and throw the patient over our shoulder and walk them out? How much weight does the average soldier who's in full kit weigh? We think a couple 100 pounds, right? I mean, I'm not moving anybody anytime soon. I mean, I'm a soft target if I'm out there trying to move somebody that's 200 pounds, right? But drag straps work, and I was going to demonstrate all that, which is what I typically do, but they always throw kinks in my plan. But I wanted to play a real video of care under fire of an actual provider, but because of the sensitivity of it, they're making me do this video that we made at TCMC, which is very cheesy, so just play our silly game, okay? TCMC is a medical, tactical combat medical care course. It's basically a TC3, but for providers. And the whole goal of that course is to bridge the gap between clinical and military medicine so that when you have a combat dermatologist as a brigade surgeon, they kind of know at least how to put a tourniquet on and stuff, okay? But so anyway, just bear with me with the video. This is not my preference, but just watch it, okay?
You're angry! If you're injured, you can still move! Come to the center, my boy! Over this way! Still move! Come to me! Come in! Get yourself! Let's go! Get in there!
So I know it's kind of loud and hard to understand, right? Which combat is loud and hard to understand. What was that person doing that was on the side of the building yelling? What were they doing? What's that?
Like a verbal triage?
Yeah, that's a combat triage, right? They're like, hey, if you can hear my voice and you can walk, come to me. You know, like I'm not going out to get you. If you can walk, come over here and you'll get to safety. So that's the first initial thing is to get everybody off the X if you can, and if they can help themselves, you want them to do that, okay? Good job. Okay, sorry, I keep stopping. I want to make sure you guys understand. So what just happened just there?
Get a quick result of the
So-
call.
Yeah, so the team leader runs out and is assessing for signs of life. They're still under fire. They're just doing a quick check of signs of life. And what is he checking? Carotid pulse, okay? We're not worried about blood pressure and all that circulation right now. We're just checking for signs of life. Hey buddy, are you okay? Can you talk to me? Quick carotid pulse. If there's signs of life, that means that we need to bring out teams of 2 to come and start getting that patient off the X and doing a high and tight tourniquet, and then together they will throw a drag strap onto that patient and drag them to safety. If there's no signs of life, what do? We're gonna move on. We're gonna move on to it, because CPR is futile, right? We're not gonna start CPR and be out there. So we're gonna move on, but of course, as we move forward, we're not gonna leave our brothers and our sisters on the battlefield. We're gonna scoop them up, but somebody else is gonna do that within our group, and the commander will know what to do, okay? But if there's no signs of life, we're not wasting time, resources, or manpower. We're moving on to those that do. So what they're doing is they're calling out people in teams of 2 for safety to come get this person off the X, high and tight tourniquet or not, and just drag them to safety. Told you it was a cheesy video. Okay, so they drag that patient off the X. I know it's a little silly, but at least it emphasizes a point. It's better than me trying to explain it or seeing some old lady run around this classroom chaotically, right? So what did you guys think about that? Do they seem to work together pretty good? Have you guys seen that drag strap placed on a patient before? A lot of times it can just be webbing, like 2-inch or even 1.5-inch webbing that you can buy, the same stuff we use for slings for rock climbing. And you just tie a knot in it, and you throw the knot into the center of the patient's chest, and then you wrap it under each of their armpits, and then you can tie a knot, like a half knot on the back. And by doing that, if you have 2 people who are dragging at the same time, it almost forms like little slings, and one of the 2 people may be stronger than the other person. So if you don't put that knot in the back, a half knot, you'll start kind of seesawing, and the stronger person will drag further, faster, and it starts seesawing the patient. Meanwhile, their head's bumping on everything even though they have a helmet on, they're bumping. So by doing a half knot behind the patient's head, it keeps the sling even regardless of physical strength of the people getting them off the battlefield, and it protects the head by accidentally, just theoretically, it lifts the head up a little bit just by default, and so that patient's head's not bouncing around. So then, once they got to the tactical field care phase, which we're about to do, what is their priority for care? Yeah, they probably didn't do anything right. I think they just dragged him off the battlefield. I don't know if did they throw a high and tight tourniquet on? Yeah, it looked like they did maybe what's high and tight tourniquet? What does that mean? They just saw pooling of bleeding. They assume that there's some sort of extremity hemorrhage there, and they put a tourniquet on as high as possible because they don't really know where the wound is, right? And can it be that you throw a tourniquet on under all those chaotic conditions because you saw a bunch of pooling blood, and after you get them to the tactical field care phase and you actually expose them, you realize there's no wound at all in that extremity, that it all came from the chest? Can that happen? Yeah, is that bad? I mean, yeah, okay, they had a tourniquet on for a few minutes. That's not irreversible damage. Okay, so you always do high and tight, then once you expose, you're gonna put the tourniquet on a little closer to the wound. So our priorities for care are the March algorithm: massive hemorrhage, airway, respirations, circulation optimization, right, and then protect from hypothermia. So the March algorithm kind of falls in line with the XABCD-ish but we don't have fast exams. We aren't doing a lot of those other things, and we're resource limited, all right? And a lot of times, are we using our own equipment with this basic stuff so far? What are we using? Yeah, we should all be carrying what's called an IFAC, an individual first aid kit. So when I'm rolling up on a patient, or used to back in the day, I would use their individual stuff on them first before I open up my own kit. That's what their patient's wearing it for, or you're wearing it to treat yourself. Okay, so now we're in the tactical field care phase. Does that mean we're completely out of danger? What is this? It says tactical field phase. What is that? Tactical field care. Yeah, you're still theoretically in some sort of danger, but you're not taking active fire. And again, for those of you that are really experienced, bear with me. I mean, try to at least hide the boredom a little bit, okay? Try to, be a little more enthused as much as possible so that your colleagues can learn from you.
Somewhere in the 30s. Next flyer, just Steven. Strong one. Sean, you take a hot take Strider and Strider. What happens to left crisis?
Okay, so this is not a perfect video, right? Any issues with what they're doing? Anyone? You guys get to be armchair quarterback. They skipped airway, went right to breathing, right? And they got distracted by the chest wound. So what happened is they're going to expose, because you kind of have to, and they're trying to clear the junctions. They're trying to do the rapid blood sweep, and they're trying to clear the junctions. Where are the junctions? Groin, neck, axillary area. So they had to expose those areas in order to clear them for bleeding. You would think that in real life, if there's some significant bleeding, it's pooling out, but not always, okay? Sometimes it kind of drains to the back, it's not real obvious. So anyway, they're trying to clear the junctions, make sure they don't miss a wound. And what happened is by doing that, they actually went from massive hemorrhage, or X in civilian trauma, right to breathing and skipped airway. The patient had maxillofacial trauma. They never confirmed that he had secure airway, and it can phonate or protect their secretions. In fact, it seems like the patient's unconscious. Now, I know it's a dummy, okay, they're always unconscious, okay? But in their little scenario, the patient's breathing, and now the instructor had to prompt them to, hey, you hear some stridorous breathing in order for them to do airway management. So don't skip A. So what do they need to do for this patient? Secure the airway how? There's maxillofacial trauma and you're in a pre-hospital environment. It's definitely a surgical cricothyroid, right, surgical cric. And so, again, some of this is moulage, not really great representation, but we're trying to get the students to go through the phases of care and kind of start prioritizing things. And it's so easy to get distracted and task-oriented. It's confusing. And has anybody ever tried to work with all that gear on? I know those of you that are experienced, it's hard. And what do we get when we're under duress? Or do we get smarter or much dumber? We get dumber. Okay, there's a parasympathetic overload, right? We get fight or flight. Is that sympathetic or parasympathetic? Sympathetic. Okay, so what happens to our eyeballs? We get tunnel vision, right? We kind of constrict, okay, or do they dilate? What do they do? We're talking about sympathetic, right? You're in a sympathetic overload. I know I said parasympathetic, but I was trying to see if you guys would correct me. Sympathetic or parasympathetic? What's happening? Are we feeding and breathing, or are we fight or flight right now? Yeah, so sympathetic. So what happens to our eyeballs? They dilate. They're trying to take everything in, but what happens to our near vision when that happens? It's not real clear and crisp. Okay, what happens to our respiratory rate? Increases. What's happening to our vessels in our body and stuff? They're constricting. So our dexterity is altered. And what's happening with our mind? Are we as sharp? No, because we have that sympathetic overload, right? And so, yeah, we're combating ourselves at this point. So it's a known fact that you lose your near sight, your dexterity, plus you got all this equipment on, stuff like that. So I'm not going to make you watch the whole video, but it's rapid blood sweep. They're trying to clear the junctions. They should have addressed the airway. When they went to breathing and they see this chest wound, is it really necessary to stick your hand over it and then mess around for 5 minutes with one hand trying to open up your bag and do things? I think that is so dumb. When I see people do that, I don't understand. You know, I know theoretically they're trying to cover the wound and show the instructor, I recognize this chest wound, I'm covering it so it doesn't suck anymore. But take the extra 10 seconds or so to actually open up your bag and get your stuff so you can open the wound, or, you know, like close or occlude the wound appropriately. I see so many people like struggling with one hand, trying to do everything with one hand. Now, if you have two people and there's no other priorities, then sure, one of you can put your hand there while the other person's getting their little chest seal. But if you're the lone person, don't limit yourself by doing that. That's as silly as telling somebody that's about to intubate, hold your breath before you intubate after the paralytic hits with the patient. Hold your breath so you know what the patient's feeling. I mean, that also is very bad information, right? So now you got a semi-unconfident person trying to intubate who's holding their breath and you know, trying not to pass out. It just doesn't correlate with common sense, right? So don't do that. What else do you guys see? Anything else that you picked up that you would do? I know there's lots of experience. I'm sorry, say that again? You know what?
I saw a blade and I thought he was using a natural knife.
No, he had a little curved clothing cutter.
With that chest seal on, they didn't do any assessment for any exit. That was an issue.
Right, they haven't rolled the patient or anything yet. That's very good. And there's always we always have to look for an exit wound. Anything else anybody's picking up on?
They haven't looked close.
Yeah, they haven't. They just did junctions and and they haven't even checked the tourniquet to see if it was working. Right? Okay, very good. You guys are picking up on some good stuff. All right, I'm just a little bit more. You guys just play my silly game a little bit more and we'll be done. Oh man. Okay. I guess it's kismet. Okay, you don't have to play my silly game. Okay, so they'll go on and what they would do after this, besides the chest seal and stuff, they would eventually get the patient fully exposed. They would log roll the patient once at some point, but that they're going to wait and do that until the end of their quick primary, which looks different than it does in a hospital. They're addressing the rapid blood sweep, airway. They're going to secure the airway of the cric. Breathing, they're doing that chest seal, and if there's signs of progressive respiratory distress, they would needle the patient. Otherwise, they don't. They just keep the chest seal on. Okay, what would be next in their priority of March algorithm? So we got massive hemorrhage under control, airway respirations, what would be next? Circulations, they would try to get 2 large bore IVs or at least one. If they couldn't get it, they would go IO pretty quickly so they get some TXA on board. Okay, they would try to do that even before the bird lands. If they're carrying blood, they may start resuscitating the patient with blood, but it doesn't look like they're carrying blood, does it? So at some point, when they get the litter ready and the ready heat blanket and the space blanket all ready, they would come up, log roll the patient once, check the backside, check for any kind of exit wounds, then roll the patient onto that litter so that the patient already has the blanket and everything under there, so they can only have to roll the patient once, because the more you roll, the worse it is, right, for the patient? Okay, and then they would protect for hyperthermia after that. Are you guys with me? Okay, so we already just demonstrated how combat medicine is different. Tactics rule, right? It's hostile environment. It's dark sometimes. You have to worry about light discipline, right? So that you don't put yourselves in harm's way. It's usually hot or cold. The extremes of weather. You're limited to what you're carrying on your person or what your patient has on their person. And resupply. And sometimes there's long delays to hospital care. How long can that delay be before you can get a patient to the next level of care? It could be days, right? The gentleman I told you about, Christopher Cordova, he was pinned down, I think, for a couple of days, or at least 30 some odd hours. It was awful, and so you can't get patients out. So no matter what you're doing for them, sometimes just time is not on your side. The whole golden hour concept, do we still try to abide by that? Is that real, the golden hour?
It was the height of that news and everything else. We were 15 minutes from most hospitals, but now.
Yeah, they're saying, yeah, sure, there's a golden hour. I mean, of course, the sooner you get a patient to the next level of care, the better off they'll do. But we know there's long evacuation times, so what they're planning for now is, emphasis on you're stuck with a patient for quite a long, up to 72 hours, which is pretty bad. That's the whole prolonged field care stuff. Okay, so roll 1, you guys know roll 1, roll 2, roll 3, roll 4? Okay, so an Army person, tell me what roll 1 is. Like, give me an example. Yeah, but does it have to be a battalion aid station? What if I'm injured in my vehicle and half my arm is hanging off? I put my own tourniquet on. Is that roll 1? That's considered roll 1. Okay, Air Force, tell me what a roll 2 is. For you guys, what's an equivocal roll 2? You guys have 4 aid stations? Okay, and what assets do you have there? Okay, so like an Army roll 2. Anybody else?
That or something that goes to this, surgical teams that might need that intermittent care to keep the medical line.
Yeah, so roll 2 is usually you have, it's a brigade or division level, and usually there's quite a few medical assets. And by doctrine, at least for Army, we have lab, x-ray, and a dentist. Okay, and if it's a roll 2 plus, you actually are augmented with a forward surgical team. And so that's what roll 2 is. So if your roll 2 regular has no surgical assets, but you have lab, dental, and x-ray, but a roll 2 plus has surgical assets assigned to it. What about a roll 3? This is a core level asset. This is like your combat support hospitals. Air Force, you have an equivocal roll 3. What's it called? Like a type of hospital? Because I don't know what it's called either. I'm not Air Force. I'm always deployed and there's not been. I think it's a mobile forward surgical team. You guys have MFSTs? You guys have those? Not sure. Okay, that's okay. Okay.
Usually have a certain
Yeah, you guys do have some assets for roll 3. It's very similar. Navy. What about Navy? Does Navy have a roll 3?
Yes.
What is it called? Yeah, it's a roll 4. But you guys have a CRTS? Is that okay? Med battalion. Okay. Okay. It almost sounds like a roll 2. My understanding that you guys also have, you know, like fleet surgical teams, and then some of your ships are considered Role 3 facilities, right? As far as capabilities, they have surgical capabilities. Okay. Okay, so the big carriers, okay, they're considered Role 3. I'm glad this is really clear. Okay, let's just go with this. Role 1 is self or buddy aid. All right, I'm not going to try to make it purple. I'm just going to like purple meaning like all services. Role 2 is a brigade or division level asset with lab, dental, or X-ray. If it's augmented with a surgical team, it's called a Role 2 plus. Role 3 is a surgical capacity. When I was with the CASH, the 31st CASH in Afghanistan, we had every kind of surgical specialty. Like we also had a terrible PA commander who was relieving her cause, which was awesome. But we did some great medicine during the time. And we had a vascular surgeon, we had orthopedic surgeons, we had a neurointensivists, we had an ENT, OMFS, we had a cardiothoracic surgeon, who was our DCCS. So we were doing as many terrible, like seeing those terrible cases like Bastion was, and actually saw more patients than they saw in Bastion during that year because we had so many great capabilities. We did all those thoracotomies because we had a CT surgeon with us, not because we were just being willy-nilly. We had somebody that could surgically correct them, which is why we did it. Now, Role 4 is out of theater, so that's your launch stool. That's where we evacuate all of our patients out of theater to, traditionally to launch stool. And Role 5, we'll just say our hospitals in the United States, like BAMC, MAMC, you know, Walter Reed, stuff like that. Just try to keep it clear like that. Okay, equipment. What do we have for equipment? Who determines what equipment we have? You get to just choose and order? Yeah, you have something called SKO, Sets Kits Outfits, and it determines what you have. There's a TC3 or also TCMC SKO. You have a Role 1 specific, a Role 2, a Role 3. And you're supposed to be given this set of equipment. They update them how often? They're supposed to be 5 years. So you'll go to a board, vote if you get lucky enough to vote on what equipment you need. And like sometime in the next 5 to 10 years, it'll actually make it into the Sets, Kits, and Outfits. So the process is tedious and lengthy, and it's not necessarily devoid of corruption, okay? And I'm not kidding. So a lot of times we, regular conventional military, will try to follow suit from the Special Forces and Rangers because we think that they get the best of equipment. But sometimes, and they usually do, right? They have a nicer budget, they have a more important mission, you know, than the rest of us, truthfully and tactically, more austere. But sometimes there's some corruption within the chain where somebody is retired now and they develop something, or they have a relationship with a business, and the next thing you know, that's getting put into the Sets, Kits, and Outfits. One of my deployments, we had, I don't even know, 1 million eye shields that we would never need, right? You know, there's only, even if you counted both eyes being injured of everybody in theater, we had more eye shields than we could, than we needed. So anyway, I just warn you, this is things that you don't learn, that you can't read in a book, that when you're trying to advocate or if you get invited to sit on an SKO board, do it. And find the best off-the-shelf commercial product that's gonna save lives on the battlefield, and make sure that there's not somebody who's retired colonel who used to be an ER doctor created an airway device that is now everywhere that's not really functional. Okay, so I'm just saying. Okay, but they're predetermined, so if you have some say-so, do it. That's awesome. And then it's usually organized, and you have to further organize that so it's actually functionally available, because it's just in a big box. And then you want to always have a 9-line medevac card available. Okay, remember the MIST report? You at least have to know a MIST report. So if we're treating a casualty on the ground, we did our tactical field care, we're going to try to evacuate this patient. At a minimum, we're going to have to provide our command and control element a MIST report so they can communicate with the medevac team when they do the 9-line what's going on. And that's going to come from you, the MIST report, all right? Or one of your medics, but probably you. And then who does the 9-line medevac request? Do you have to do it sometimes? You might have to, so always have a card because I can't remember all that stuff. Personally, usually, hopefully, you'll have some other like MSC officer or somebody else with you that can actually organize that for you, because you're busy doing treatment and overseeing patient care. So hopefully, somebody else can do this 9-line request But you have to give them the right information. Hey, make sure they bring blood, make sure they bring a ventilator, that kind of stuff. I'm gonna need a traction splint, or I'm gonna need, whatever, 2 ventilators, or, just make sure you communicate what's necessary from that team. So the 3 objectives of TC3, and I know I'm kind of drawing this out, but the 3 objectives are you're gonna treat the casualty, try to prevent additional casualties, but the real thing is that you're gonna continue the mission. So whatever you're there for, you're gonna continue the mission, and that's the priority, all right? You guys need a break already? No? Okay. So what's TC3? We kind of talked about it. It's a highly developed, standardized pre-hospital guidelines, and the whole goal is to try to prevent preventable deaths on the battlefield. There are some deaths that are just not preventable, right? What are those? Yeah, catastrophic head injuries, right? I mean, complete blast where there's no, discernible parts left of a person, right? They're just not survivable. What are examples of survivable injuries? An amputation, an isolated amputation, right? You should be able to throw a tourniquet on that person and save their life. What else? Yeah, small arms fire, little things, maybe we can go in there and stop the bleed, just small junctional wounds, small things. Tension, hemopneumothorax, that's preventable. Once that person has a big hole in their chest and you've covered it, and now we're doing positive pressure ventilations like we're breathing for them, we're creating an environment that's going to eventually create a tension pneumothorax. So you've got to be able to recognize that and treat it. It's treatable, okay? And then loss of airway. Remember a few days ago I said, what's the #1 cause of loss of airway in both civilian and military trauma? It's the tongue. We were throwing these casualties down who maybe lost a lot of blood, not secure in their airway, tying them to a litter, strapping them and taping them down and sticking them out on the back of a bird. Next thing you know, they go unconscious and they choke on their own tongue. That's completely preventable, and we're not going to make those mistakes. And we're really good at not doing these things now, which is pretty fantastic. So again, TC3 is organized into 3 phases: your care under fire, tactical field care phase, and then once you get the patient ready, there's a casualty evacuation phase. Now, ideally, in a perfect world, you'd have a nice helicopter land, you'd be able to load them up in the helicopter, and they go away and they get to a hospital really fast. But that's not always the case. Sometimes we have to pick them up and take them with us. Sometimes we're putting in a non-standard, whatever vehicles in our convoy, and moving them and hauling butt to the next level of care, right? You guys experienced that before? Some of you have, and that's real. We talked about this. Fire superiority is the phase 1 care under fire priority, and if you do any treatment at all, the only thing you should be doing is high and tight tourniquet and getting the patient off of the X. All right, that's the only kind of treatment. It's only massive hemorrhage control. It's usually the extremity stuff. You don't even have time to pack junctions here. You're just getting them off of the battlefield so you can do more detailed care. All right. Cat tourniquets, do you guys all feel like you could put a cat tourniquet on each other effectively? Like seriously, by show of hands, is there anybody who's never done it before and would like to practice? Everybody's done it? Like in some sort of training? I'm not trying to single you out, but even you, Air Force, like you guys, seriously, you guys have done it? I mean that with nothing but affection because they don't prioritize some of the training, seriously. I'm just asking, okay? Okay, good. All right, well, we'll have an opportunity in our lab anyway. High and tight means what? High on the extremity. And what is tight? Does that mean I turn the windlass device 25 times? Is that super tight? What has to be tight? The initial Velcro strap has to be tight. The windlass should only need to be turned 3 or 4 times max, and that should shut down the bleeding. Okay, if you don't have it on initially correctly tight enough with the Velcro, you'll turn that thing all day long and it won't shut down the bleeding. So you have to get that's the tight part, and high up on the extremity so you can salvage. Okay, I know this seems silly. I'm just making sure that you guys know this stuff. Your medics are gonna be looking to you to make sure you know. Tactical field care, by definition, we're no longer under effective hostile fire, and this is where you do your military or pre-hospital primary survey, which is your March algorithm. I think this is a good time to take a little break. Why don't we take a little break, move around. Let's take 10. I tease around a lot with my Air Force comrades. Really, I'm trying to educate myself because I don't know what it's called in the equivocal. But I do know each time I've deployed, there's always been Air Force there. They've always been with us and Navy as well. And, I mean, I'll be honest, I've never seen a Coast Guard on one of my deployments, but that's probably right? They shouldn't be there. They're doing other big missions that I've never been on, like the icebreaker. I do that not to pick on Air Force. I really just don't know the chemicals, so I'm trying to educate my own self. And I don't feel like they invest enough time in your sustainment training, whereas a lot of the Army folks, they get that sustainment sometimes, but really it's just an expectation that Army knows it and you know it enough to teach it to your medics. And so I appreciate y'all bearing with me during this kind of military review that has nothing to do with your PANCE exam. And but these are expectations that the military has in all of you. So anyway, we talked about March. You guys are tracking. That's our primary survey in a pre-hospital military environment, a little bit different. So during the tactical field care phase, we're going to expose the patient, right? Just like we saw in the video, they're clearing junctions and they got kind of distracted with the chest wound. If you see a patient that presents like this, what do you think is going on here? Do you see anything wrong with the picture? There's some arrows. Yeah, there's two tourniquets. They did the right thing. They had the gist, right? They were like, oh, they're still bleeding from this mangled extremity, and we expected that a tourniquet, one tourniquet may not work, right? Because we have a mangled extremity that looks like there's a disarticulation at the knee. And so those tourniquets don't work if you don't have good long bone that's intact to squish the tissue against between the tourniquet and the long bone. So they knew that, so they put a second tourniquet on, but they have a gap in between, so that's going to cause a compartment syndrome. Do you know that there's a new tourniquet that's coming out? I don't know if the military is going to use it or not, but it's almost like an AED. It's for lay people, so it's going to be like in a cabinet, just like next to the AEDs. And what you do is you open it up, and it'll say "put above the wound." And you open it up, you put it above, and it detects the patient's pulse and will actually compress with so many millimeters of mercury of pressure, just automatically, kind of like the shock button on an AED. That's a new thing. That's that because shootings are so prevalent in the United States. That's where we're going. And I anticipate they're going to be in schools at some point. But anyway, we don't have those right now, so we have to subjectively look at the patient and say they're still bleeding and place a second tourniquet on, but it needs to be kissing tourniquet. So all of these things are happening during the tactical field care phase. Also, we're going to get a quick assessment when we're in the tactical field care phase. We're going to correct, improve, convert tourniquets. And what do I mean by convert a tourniquet? Initially, it's high and tight. What do I mean by converting it? So yeah, once we expose the patient, there's a high and tight tourniquet way up here, but maybe the wound is down by the elbow. So we might move that tourniquet down to a couple of inches above the wound so that we can salvage as much tissue as we can, all right? But initially, when you're under fire, or at least in the early stages, you're doing high and tight. And then they're doing a rapid blood sweep. Now during this, some people will go ahead and do a quick radial pulse. That really falls under the C portion of the March algorithm. But when you're first assessing a patient for signs of life, you're going to check a pulse. Is it weak and thready? Is it strong and bounding? You know, you're kind of going to get an assessment of their circulatory status real early. But anyhow, airway control. We don't have a lot of options. In fact, the new TC3 guidelines, they pulled the extraglottic airways out of the airway management. Have you guys seen that? Those of you that keep up on it? I still teach it because you need to have some other alternative method when you can't intubate and they don't have maxillofacial trauma. Do you really want to crack everybody? I mean, you'll be successful at it just if you know anatomy, but I would rather not have a hole in my neck if I didn't have to. But the new TC3 guidelines are pulling these out, but Tentelli has not pulled out the extraglottic airways. So this is an iGel, which I personally enjoy. I think it's a great airway device. It's hard to secure in a pre-hospital environment. As soon as you move the patient around, it breaks the seal, and it's hard to keep it in place. But you either have a Crite kit. This particular one's an H&H. They have the North American Rescue has a Crite kit. You get to play with all this stuff during our EMED lab. And then, so you're kind of, relegated to NPAs, a nasopharyngeal airway, an extraglottic, only if they have no gag reflex and are completely unconscious, or a Crite. Those are your airway tools in a pre-hospital environment. Can anybody think of anything else they can use to secure the airway in a pre-hospital environment besides what's listed? Yeah, just positioning. That's the only other thing. Very good. Nailed it. All right. Now, when we go through, we're on MA now, R, respiration, synonymous with breathing. We know we place chest seals on these wounds, right? If there's any kind of hole between the chin and the belly button. Does it matter what kind of chest seal? This, as you can see, is just a piece of plastic. It's called Halo. There's 2 of them in this bag. It's not vented. Is vented better than non-vented? I mean, theoretically, they say it is vented. This guy developed this Bolin chest seal when he got inspired when he was opening up a fresh pound of coffee, and it had that little seal. And he's like, "Oh, I'm gonna make a chest seal." And then he sold it, and now he's living on the beach somewhere or something. But anyway, this is vented, and ideally it's supposed to be better than non-vented, but all vented chest seals become non-vented pretty quickly. They all get clogged, and they're not venting. So anyway, we do want to make sure we cover all the wounds in a pre-hospital environment. Just to be clear. If there are signs of tension, what do? Finger or needle thoracostomy. Second intercostal space, midclavicular line, or for the needle, or you can do 4th or 5th intercostal space, anterior or mid-axillary for finger thoracostomy or needle, either one, if there's signs of tension. Remember that, because you're going to get it again in surgery 3. You know signs of tension. Tell me some signs of tension in the thorax. Late signs, tracheal deviation. Okay, they start becoming hypotense, right, because it decreases venous return. What else? Yeah, I mean, they're having progressive respiratory distress, and somebody you knew had a chest wound, okay? All right, we need to have at least the 3 1/4-inch needles. Some of the new ones are even longer. And so the key with that is that you don't hub a super long needle. And that goes for pediatric patients too. If you have to needle D a pediatric patient, there are not special needles for them yet that we have in our sets, kits, and outfits. They exist, there's a Veres needle, we just don't have it in our sets, kits, and outfits. So anyway, you don't hub this needle in a pediatric patient because you're gonna hit some vasculature. You only insert it enough to where you hear air escape, and then you pull out the needle and disadvance the catheter so you don't cause damage. But we, for adults, need at least a 3 1/4-inch long needle, but some of the new ones are like, what, 6 or 7 inches long? They're pretty long. So don't hub those, just insert them enough till you hear air escape. All right, circulation, let's get on. We gotta at least do a saline lock in a pre-hospital setting. We need access, and why? If we don't have blood products, why do I need access? We want to give meds, right? Combat wounds hurt. They're painful. So we want to give some pain medicine, right? Is that my priority, or is TXA first? Probably TXA, and we want to give some pain medicine. But what if you don't even have an IV yet? Can we give pain medicine any other way? We can do IM. You can do intranasal. We have these little atomizers. Has anybody heard of an atomizer before? I usually have one up here. An atomizer is a little spongy, triangular shaped device. They always end up missing out of my stuff, but I'll bring one in. And you'll see it during our lab. Anyway, it's a little spongy device that just screws on the end of any needle. So you can take any IV medication and draw it up and insert it into the nose, and it makes those atoms super small and aerosolizes them. And so you put half the dose in one nostril, half in the other, of whatever IV pain medicine. So let's say it's ketamine, for instance, you can give a little in each nostril, up to like 25 milligrams, and it gets absorbed via the olfactory nerve directly into the brain. Okay, so that's pretty awesome. I guess that's why people snort drugs, right? It goes in right away, and you get effects right away. So if you don't have IV access and your patient's writhing around in pain, address their pain, you can do some intranasal pain medicine. Is there any other methods or mechanisms that we can deliver pain medication? You said IM, IV, IN. What's that? Oral? IO? I mean, you could go PR, you could go rectal, okay? I appreciate that there's always somebody in the audience. That would be the last ditch if you have no other method. But good job, you're right. I love the way you're thinking. Okay. All right, IO is a good one, and we want to give that TXA and get that on board right away. 2 grams right away. So here's our IOs. We actually have an additional IO that we use only in the military. These these easy IOs we do not use in civilian trauma at all. That's a military specific thing, and it goes right in the sternum. And does it work? Yeah, it works really good, as long as you do it right? It takes quite a bit of pounds of pressure, but all these needles just kind of secure the device, and only a tiny one goes into the manubrium or the sternum. And the flow rates with these guys are faster than any other IO. Under a pressure infuser, if you had blood or fluid under a pressure infuser, you could give 90 cc's a minute through the sternum, which is faster than any of the others. This is 90, this is 60, this is like 30-ish. So anterior tibial or a pediatric catheter, which is this pink one, they can only do about 30 cc's a minute. This is about 60, which is a humeral, the yellow one's a humeral one. And then the easy IO in the sternum up to 90 cc's a minute with a pressure infuser through the IO, all right? Okay, we talked about TXA. Why do we know that it works? Is there any kind of evidence-based medicine that we've used to tell us? There is. Does anybody remember the study, the landmark study that told us this is good to use? The CRASH-2 study, right? And the CRASH-2 study basically studied 20,000 or more trauma patients across the world, and they were given TXA. At the time, they were given initial gram over 10 minutes and the second gram over 8 hours. But anyway, long and short of it, there was a relative risk reduction of about 5%. So it made a statistical difference if you gave TXA within the first 3 hours of entry. So the military went behind them and they did a study called the MATTERS study. And it stands for the military application of TXA, something that spells matters, okay? And in their study, they actually showed a risk reduction at about 15%. In other words, you could actually reduce death by a significant amount if you did TXA, but they also realized that the most beneficial patients were the ones that were the most severely injured. So the worse you were injured, the better TXA worked for you, and there was a larger risk reduction using TXA. So that's why we do it within the first 3 hours, all right? Calcium, we give that. There's 2 forms of calcium, and remember why we give calcium? Yeah, because all these citrate bags, when we try to do blood, when we give these blood bags here, when we take them off of a donor, they have a little citrate in them to keep the blood from clotting before you put it into the patient. That citrate binds to calcium and causes hypocalcemia, and your trauma patients are already hypocalcemic. So calcium comes in 2 forms. There's calcium gluconate and calcium chloride. This is calcium gluconate, and it's a larger bottle, whereas calcium chloride comes in a smaller bottle, okay? But they're both the same. They're equivocal, but this is less dilute than this. So you aren't supposed to put either through a peripheral line. You can do them through IO, but you really should do a central line or IO. Or you just do a slow IV infusion over 10 minutes, okay? So that's kind of difficult to do in a pre-hospital setting. So that's why we usually give calcium gluconate, because it's already kind of diluted. It's 3 grams of calcium gluconate, which is equal to 1 gram of calcium chloride, because it's kind of diluted, and it is less caustic peripherally in the line, okay? Did you guys already know all this stuff? No? Okay, good. At least I'm teaching you something. Okay, so we know if we get to the point where we can resuscitate a patient, they need blood, right? They've lost blood, they need blood, right? Do we have blood readily available? Are we carrying blood around? Some units do. Do most units carry blood? No, so if you're in a battalion aid station, you're gonna have to set up a walking blood bank program. And that's a whole nother class and lecture. But before you deploy, like if your unit's deploying, the Armed Forces blood program will come out and actually test every single person in your unit for their blood type and actually build a roster for you. And what you really want is to know who your O negative people are. Your low titer O negative people. Who here, by show of hands, knows that you're a low titer O negative person? Who here, by show of hands, is just O negative? You're not sure about your titer status? Oh, come on. You're afraid of being singled out, because I'm totally gonna bleed you if we have a mass calendar. Okay, I don't blame you for not speaking up, but low titer O negative is the best for everybody. And they will test for titers and stuff, and they'll come out and do it. So up to, I think, 25% of dog tags are actually incorrect with the blood type. So you always wanna confirm, and before we do a walking blood bank, you confirm one last time with a quick Eldon card, and I'll show you that in a moment. But anyway, we want to give whole blood if we can, because it restores all the factors. It's got clotting factors, volume, oxygen carrying capacity, things we've already talked about. All right, if you have to give fluid because they're hypotense and they have a brain injury, and you're like, hey, I've got to try to get their pressure up a little bit because they have a brain injury, what's our best fluid of choice if we had to give some sort of crystalloid? We have to. Yeah, it'd be great if we had fresh whole blood or 1:1:1 or even some plasma or freeze-dried plasma or PRBCs, but we usually don't. So the best one would actually be something called Plasma Light A. A stands for alkalinizing solution, but it's not in our sets, kits, and outfits, so we don't have that. LR would be the next one, but we usually don't carry that either. So normal saline is what you're stuck with, all right? I think in your career time, you guys will start seeing freeze-dried plasma, which would be great. Has anybody here ever used it? Some of the special operations units and stuff actually has freeze-dried plasma. We had it back in Vietnam War. I wasn't a part of that. I'm not that old, just so you know. I do some research on some of the stuff. But historically, you know, it went away and now it's coming back. Okay? I don't know why that was funny. Anyway, so in a military setting, the endpoints of resuscitation, because you're in a pre-hospital setting and you don't have all the bells and whistles of resuscitation monitors, we go by mentation and palpable radial pulse, and that's enough. And here's a concept that's going to blow some of y'all's minds, and you'll get it wrong on the exam because I'm going to ask you, I'm telling you right now, I'm going to ask you about a concept called permissive hypotension. What is permissive hypotension? That is where we allow you to be hypotense, meaning that the radial pulse is fine. In the real world at BAMC, I would never just allow someone to have just a radial pulse. We would go by their actual blood pressure. We want them 110, 120, at least over 100, right, if they're traumatically injured. But in a pre-hospital setting in combat where you're resource limited, my endpoints of resuscitation is you're mentating and you have a radial pulse. A radial pulse is synonymous to about an 80 or 90 systolic pressure. Is that adequate for the real civilian world? No. But in a pre-hospital resource-constrained environment, we are going to allow a little permissive hypotension. There's a caveat though. That's your brain injury patients, right? We don't want them to be hypotense ever, because if they're hypotense even once, it increases their mortality by 150%. That's huge. So if they have a TBI, we want to keep it at least 110 to 120, and that means we may have to give them IV fluids, which is the exact opposite of everything I've been teaching you, that IV fluids and trauma are bad. Okay, there's an exception if you're military and you're pre-hospital and you have nothing else, and you have to keep their pressure up. Otherwise, we allow for permissive hypotension, only in a military pre-hospital environment. Why do we do that? Why do we allow it?
You're able to perfuse, you're saving resources, you're not blowing clots.
You're perfusing enough, you're saving resources, and more importantly, you're not over-giving them a bunch of fluids to cause a dilutional coagulopathy, actually blowing the patient's own clot and protective factors out of the water, like with giving them too much fluid. So that's why we're doing it. But if I give you a scenario and you're a PA in a hospital, you're not going to allow permissive hypotension. This is a pre-hospital military thing only, okay? I promise you some of you will get that wrong. I hope it's a 100% question, okay? I'm telling you, I'm asking you this question, okay? Are you with me? Okay, because it's important. All right, so in tactical field care phase, we're still in circulation, this is a good time to give pain medications and nausea medication, right? Because pain causes nausea, pain medications cause nausea. What are our options for pain medicine in this environment? Do we have, what do we have? What do we carry around? A lot of times we'll have ketamine, right? Ketamine's a great drug. I've never had it myself, but I love giving it to my patients. It's actually awesome. There's a difference though. You can give them a sub-dissociative dose, like a low dose that just addresses pain, but if you give them a little too much, you put them into a dissociative state, or the non-medical term is you put them in the K-hole, right? Nobody wants to be in the K-hole if you don't want to put them there. Do you guys know what that is? They start getting combative, and it's a dissociative, so they start kind of freaking out and stuff. So if you're trying to give them just enough for pain, you want to give them 25 to 50 milligrams, no more than that. And I'll be warning you, some people are sensitive enough to it, even 50 milligrams might put them in the K-hole or dissociate them. Once you get them into the dissociative realm, you're going to have to counteract that with some benzos or something, because when they come out of it, they get combative. They're very. It's a very terrible thing. Anybody ever seen a patient come out of a K-hole? It's bad. Okay, if you put them there, just keep them down. Keep giving benzos. Just keep them sedated. All right, and then get them to the next echelon of care. All right, that's my life advice.
You can get away from 50.
What's that?
For some reason, 50 milligrams seems to be that dose that just sets most people off, like an aggressive
I-
So we try to stay at either 20 or we go all the way to 200.
Well, I agree with that, because if you're gonna put them there, you might as well just keep them down. Now, ketamine, a lot of people think it's a long-acting drug, it's not. We're gonna learn this in the airway lecture, it only lasts about 10 or 15 minutes. So, they'll come out pretty quickly if you give them too much. So 25 milligrams is a good dose to start with ketamine. What are other options? If you have fentanyl, you can give fentanyl. Fentanyl is really nice, it's a very hemodynamically stable drug. You can give them 25 to 50 micrograms is how that's, but it can cause some respiratory depression, but not as much as some of the opioids. Anything else?
I've had Percocets.
Yeah, you can give oral meds if it's just like a extremity injury or a fracture. You can give oral medications. I used to carry that stupid ammo can around that had like Percocets and stuff in it. I had to chain it to my bunk and stuff at night. It was really terrible. I hope they have a better system for y'all now. But anyway, are there any other options? Do we have anything that's not IV or anything? Yeah, we have fentanyl lozenges. I actually have a couple in my office that I'll bring out. And so they're fake ones, of course, because if they were real, I would have them at home, okay? Anyway, they're fentanyl lozenges. They come in 200, 400, and 800 micrograms. So if somebody has pain, or if you're dealing with a Mezcal, you just stick one of those little lollipops in a bunch of people's mouths, and at least it starts giving them some pain relief. And it gets absorbed transmucosally through the oral cavity and through the gastric contents. What happens if your soldier says, "You're not doing enough for my pain," they just eat it? What happens? Will they just all of a sudden go into respiratory distress and die? No, they just neutralize their fentanyl lollipop with their gastric acid, and it will not, very little, or not very much of it will actually get absorbed. So they just ruin their own lozenge. So that's why it's designed, that's why it's pretty safe. So you can put a couple in their mouths as you're doing a Mezcal or something to address their pain early, or you can give a little squirt intranasally of fentanyl or ketamine or something so you can address the patient's pain, especially if you're doing multiple patients at the same time. I've even seen people put like 2 or 3 lozenges, not of the 800 micrograms, but like you only have 200, so you might do a couple. I've even seen people teach where you're supposed to safety pin the lozenge to their sleeve, so if they pass out, they pull out their own lollipop. Or you could just monitor your patient, okay? That's probably preferred. But sometimes in Mezcals, we may not have enough people to go around. So that's some pain medication options. What about nausea? What do we like to use? Yeah, ondansetron. Dr. Love published a study many years ago that actually if you have somebody sniff an alcohol pad, we used to do it in postoperative nausea vomiting, but if you sniff an alcohol pad for about 30 seconds, it'll actually curb nausea for about 14 minutes or so, which is pretty cool. So she published that in the Journal of Emergency Medicine, which is really awesome. And then antibiotics, we're going to talk about that. What are the antibiotics that they like to teach everyone to use downrange for everything, every dirty wound? It's always a gram of ertapenem, okay? Even though ertapenem is a big gun, right? I personally would use like a cephalosporin or Rocephin. We kind of joke that it's orthocillin, okay? So if there's like an extremity wound, you would do like a Rocephin, Ancef, some sort of cephalosporin. And if it involves the chest or gut, then you do ertapenem. But the medics are being taught that all combat wounds are dirty. They're all Acinetobacter infected, and so they want everyone to give ertapenem for all the wounds. You guys, is that what you were taught? Okay, so just remember that. Okay, so hypothermia, head injury. How do we protect from that? We have these little hypothermia management kits. Has anybody seen those before? These HPMKs. So this is just a space blanket. That'll help some. This is the HPMK. It's a space blanket-ish with a stupid hat. And it costs like hundreds of dollars more, okay? And some of them have like one of those little ready heat blankets in it as well. And so those are disposable. They last about 8 hours, but they work. They're really nice. But you do want to protect your patient from hypothermia, and if they have a head injury, you want to elevate the head of the bed. Here's what I was talking about as far as pain management goes. Here's what the transmucosal fentanyl lollipops look like. We used to carry pill packs on ourselves, so if we got injured, we could take an antibiotic and a pill, or if we got an attack, some sort of NBC attack, we could actually take our Valium to try to mitigate some of those, but it turns out people were taking them when they weren't under attack or injured, so they thought that was a bad idea. So I don't know, you guys doing pill packs these days? I don't think so, you've never seen them. Okay, I'm dating myself. Okay, but we used to do this, we we'd have a nice little 3M earplugs that didn't work. That's why we all have hearing loss and tinnitus. And then we'd have, right next to that, we'd have the little pill pack. And then people would just get bored on a slow Friday night at their aid station or whatever and take them. So we don't do that anymore, which is good. We do have Zofran and stuff like that. You can also just give them Tylenol or Mobic, things like that for discomfort and pain if it's mild, especially if it's orthopedic pain, which really, let's be honest, most of the injuries are non-DNVI, they're non-battle injuries from like playing football or frisbee or combatives. I've seen more injuries with that just collectively than I have trauma. Anyway, here's Nvans or ertapenem. That's the 1 gram that they give for everybody. If it's an isolated extremity wound, you might use Ancef. Again, I call that orthocillin, because every kind of orthopedic injury, that especially if it's an open fracture, the orthopedic surgeons are always like, hey, give me grandma Ancef and call me later. So anyway, they're always dirty and contaminated downrange, so you want to cover them. All right, so now we're getting ready. We got through tactical care under fire, the tactical field care phase, went through our March primary survey. We've checked the backside of the patient, we've put them down on the litter, we've got them wrapped up, we're protected from hypothermia. We are notoriously terrible at documentation. But what are we supposed to document on right now? It's a TC3 card, okay? It's awful. And if you don't have a Sharpie, you can't write on it. Like a regular pen doesn't write on it. It has to be Sharpie, or you can kind of etch it in, like an Etch-a-Sketch. But now they're coming out with new technology where there's something called BatDoc, and it's a little device that we're gonna be wearing. And so what you'll do is you'll come up on a patient and you'll scan like their whatever identification or a QR code or whatever, just scan them. It goes into this little system. You'll document everything. It kind of folds forward from your chest. You'll document what you did. You close it. You evacuate the patient. That QR code goes with the patient. The receiving hospital receives it, scans a QR code, and magically all that information populates into their electronic health record. And that's a system called T-Systems. And then they can just on-go care from there. And then once they evacuate to Lawnsville or whatever, a QR code, and they transfer the information. And to date, the military has spent billions of dollars creating this, and it doesn't exist in its entirety yet, and none of them can communicate with each other. Okay, yet. Okay, of course. All right, but that's what the future should look like, where we can do easy patient transfer of information. But historically, we're terrible at documenting. Terrible. When I deployed with the CASH, we did all those trauma patients. We gave THAM, and years later, I was like, I want to study the effects of, did THAM really work instead of sodium bicarbonate for some of these acidotic Marines that we resuscitated? And in the database, and we even had a whole dedicated team doing documentation for us while I was with that deployment. And I could find 10 people who had documented THAM use, when I know that we gave it to hundreds, if not thousands of times. So we're just really bad at documenting. Documentation is important. It's important for everyone for long-term, ongoing efforts to try to prevent death on the battlefield. So do your best to document. Sometimes your time runs out because you're too busy treating. But if you have an extra body there, they don't have to be medical. Just have them write stuff down so it can populate in that patient's record. All right, we want to splint everything, wrap them up, try to get as much medicines on board that will make the patient comfortable. Make sure you do a face-to-face handoff with the flight medic or whoever's evacuating the patient. Talk to them. Even though it's loud, let them know exactly what's happening so that they know what to do en route. Has anybody here ever tried to do any kind of patient care in the back of a moving helicopter? Yeah, it's really easy, right? I mean, you can get behind the head. If you had to intubate, you could totally do that. And if a couple people crash, you could totally do CPR, intubate them, right? Am I wrong? Are you space limited? Is it hard to see or hear anything or know what's going on? Yeah, all that stuff has to be done on the ground before you evacuate them. Although they're probably pretty awesome and could do it, that's not what their purpose is, right? So you want to make sure all that stuff, all your bells and whistles and everything's teed up before you send them off. They need to know what's going on. All right, special situations. Real quickly, mass casualties. There's an ID-ME that the military still uses for triage that's immediate, delayed, minimal, and expectant. And back in the day, they would have it color-coded. So like your delayed patients would be laying right next to your expectant patients. Can you imagine being dragged to the expectant pile and you're still awake in some capacity or aware in some capacity? Hopefully you wouldn't be, but You should have non-survivable injuries, but we kind of got away from that, but they're still teaching the IDME concept. And now, if somebody's expectant, they'll have a whole different part of your unit pick up that patient and move them to a morgue area or a collection area. So we'll talk about that. We don't do CPR on the battlefield, and we don't do it, it's just futile, right? We barely do it now for civilian people, and we don't do it for trauma very often, just because they don't do well. I am gonna talk about the burns. Remember that in these patients downrange, especially when I say downrange, I mean deployed environment, sometimes a rollover accident, fire, they're a blunt trauma patient, maybe they're a penetrating trauma patient. You just have to remember burns are a distracting injury. All right, burns can be treated over time. We don't need to do anything right now except for stop the burning, right, if they're still burning in some capacity. Otherwise, they're a trauma patient first, and that fluid resuscitation needs to happen later. We were actually killing people on the battlefield by giving them too much fluid, which causes an abdominal compartment syndrome, and they would die from that and not their other wounds. So just remember, burns are distracting injury. Treat the patient in your March algorithm, do everything else first. Noted, I see that they're 80% burned. I'm gonna just keep going on with my March algorithm. And then if you do, you're gonna, see like signs of inhalation injury, things like that. You might consider protecting the airway early, because what's gonna happen later with that airway if we don't secure it early? They're probably gonna swell. How do we know if somebody has inhalation injury? Yeah, we're taught to look for singed hair on the face, singed nostril hair, facial hair, actual evidence of burns, inside the mouth, black soot, things like that within the airway. Maybe they're already talking hoarsely initially. So in those patients, you might have a low threshold to intubate early in a controlled environment before they get on a bird and get evacuated. But we are going to start some fluid resuscitation, and you need to know this. So this is the ISR rule of 10s. And so for adults, 40 to 80 kilograms, we're going to give 10 cc's times the total body surface area. Okay, so you have to first calculate the total body surface area of the burn. And do we calculate all burn, like first degree, second degree, or partial thickness, full thickness burns? Superficial, do we do superficial, partial, and deep? How do we calculate the percentage of burn? It's just partial thickness, full thickness, or what used to be called second and third degree. Superficial burns like a sunburn, we don't care, okay? That doesn't count. It's only if it's partial or full thickness. You calculate the TBSA, and then you give them 10 cc's of fluid for every percentage of TBSA burn per hour. And so for every 10 kilograms above 80 that the patient weighs, you give them another 100 cc's per hour. All right, so there's some math in there. All right, and then we monitor to urine output. All right, so let's say a 90 kilogram patient has 40% TBSA. How much fluid do I give that patient per hour? So we're given at least 10 cc's. And I said they were how much burned? 40. So we're going to give at least 400 cc's per hour, but they weigh 10 over 80. So we're going to give another 100, so it's 500 per hour. You guys did that really quickly. Good job. Okay, nailed it. All right, I know you're over it. We're almost done. This is the IDME cards that you might have to use for triage. Some of the new, like, legit MASCALs that people have been in, like Uvalde, like throughout the U.S., they do they're either red or dead. So in other words, if you do combat triage, you say, if you can hear my voice, you can walk, you come to me. Those are your walking wounded, your minimal people, right? Everybody else is either immediate or delayed or dead. So some people consider immediate and delayed altogether, and they say it's either red or dead, like meaning you have to do something now or they're dead. So, but Tintinelli and the military is still using this IDME approach. Whatever you decide to do for triage, if you have a MASCAL, do it quickly. And you just do quick intervention. So if somebody had just an ankle fracture, there was a MASCAL, let's say you have 5 patients, one's an ankle fracture, one's a penetrating chest wound that they're having some respiratory distress, one's a catastrophic brain injury with brain matter exposed, One's an evisceration of the bowel, and one is a closed fracture of the right arm. Of those patients, if you can remember all 5 I just said, which one would be immediate, that you could do something to save? Respiratory distress, okay, that's your immediate. Which one was kind of delayed, need help, but they're alive right now, there's nothing you can do? I'm sorry? The evisceration, very good. Okay, what about the others, the arm fracture, ankle fracture, and I don't remember what the other one was? Yeah, okay, 2 minimal and 1's expected, very good. Okay, it's not that subjective. So here's, Titnelli also gives you this method. I don't think this simple method is that simple, so I personally don't use it, but I'm supposed to teach it because it's in Titnelli. No CPR while under fire or in a pre-hospital environment. Those patients are gonna die. If they're traumatically wounded, they need CPR, they're not gonna make it, I'm sorry to tell you. Make sure before you deploy that you know what the rules of engagement are for that particular unit. And usually you guys do a right seat ride where you overlap with the outgoing unit, usually, unless you're just lucky enough to be the first ones in, right? Or you're unfortunate enough to be the last ones out. Sometimes there's not a lot of overlap. So you do want to do as much as possible. Any questions about what we covered? I can tell you kind of over it today. You're like, man, I'm so just brain, like sick of being a senior. I gotta think about moving. If I have, how many more tests do you guys have? See, I knew you would do it. Okay, because that's your lifeline, right? As soon as you're done with that last one, you're done. I was gonna do a quick demo if you guys are up for it of the walking blood bank thing. Like I said, before you deploy, is this thing still going?
Yes, I'm gonna be turning off.
Yeah. Let me look.